This is a real life story of how I quit my awesome job as a clinical pharmacist of 11 years with no real plan of what I'd do next. I had a vague notion that I wanted something different, to make a greater impact, and to use different parts of my brain. I started talking to friends, then friends of friends, and so on and so forth. Now I'm discovering some brilliant career pivots proving that there is life after clinical pharmacy, and I wanted to share my journey with you. This is Career Reconstituted, how these pharmacists turn their job into a dream job, and I'm your host, Monica Mehta. I'm so thrilled to have Dr. Carol Holtzman with us on Career Reconstituted, partly because we bonded over being ID clinical pharmacists in the world of public health, but also because she is a prime example of someone who actively paved her career with sweat and tears. After pharmacy school, Carol completed her PGY1, then PGY2 residency in infectious diseases and a master's in science from the London School of Hygiene and Tropical Medicine. She then became a pharmacy professor with an HIV practice in inner city Philly. In 2014, Carol moved to Lesotho, which is a country in southern Africa with a high prevalence of HIV. While there, she worked with a tuberculosis mobile health initiative, as well as small and large-scale HIV programs, including one with PEPFAR, which is the U.S. President's emergency plan for AIDS relief. When she returned stateside, she became a senior COVID and HIV technical advisor for USAID, which is the United States Agency for International Development. Carol is a mom. She enjoys cooking, reading, and running. Carol, thank you so much for being here.
Thank you for having me.
Is there anything you want to say or ask right off the bat?
Well, Monica, it took me a while to understand pharmacy reconstituted, and when I finally got it, it was like, this is brilliant. I love it. So great job with the title of this podcast.
Thank you. Yeah, someone told me the other day, they were like, well, just looking at your title, I don't know that has anything to do with pharmacy. And I thought, well, that's because you're not a pharmacist. It's very much like an inside baseball thing for us pharmacists, reconstituting the antibiotic. But yeah, reconstituting the career. I had to be nerdy with the metaphor. But
I always love the nerd. Bring it on.
Thanks. One nerd to another. So speaking of nerdy, if you could be any drug, what would you be and why?
Oh, I'm awful at these questions. The big one that I just think of off the top of my head is probably dolutegravir. It is the main drug we are using right now for all people living with HIV that need treatment globally. It's a great drug. It's first line in the US, and it's become first line for every country in the world, including low and middle income countries, resource limited countries. And I think it's saved millions of lives, and it's also, about 20 million people are on it right now. So I'm going to go with dolutegravir.
You're very on brand with that answer. And you mentioned that everyone's on dolutegravir right now, which is so amazing to me because I always thought of, in terms of global health, that there are a lot of disparities between rich and poor countries. But you're saying that now integrase inhibitors, which is the standard of care in the United States with either tenofovir, emtricitabine, and dolutegravir, or abacavir, lamivudine, and dolutegravir, that's the standard of care in sub-Saharan Africa as well?
We have, through the PEPFAR, there's something called the tentative approval process where we licensed or approved a combination with dolutegravir, tenofovir, and lamivudine as a one pill once a day. And these are manufactured by generic companies. They're often in India, not always. And I think this is kind of the amazing thing that PEPFAR has done, is that it has made quality drugs, effective quality drugs, accessible to all people living with HIV in the world. And so, yeah, it tries to close the gap in this equity issue. So someone in a high income country does not get a better drug for someone else in a low income country. And it is, I agree with you, amazing to see that and great to be part of that.
Hmm. Well, I also remember there was a huge paper that came out a couple years ago with treatment of cryptococcal meningitis with one dose of amphotericin followed by fluconazole. And in the US, I don't know if it was under much discussion because that wasn't the standard of care in the US. People were like, how can you get away with one dose? But it was a remarkable improvement for treatment in sub Saharan Africa. So that's, I guess, like amphotericin is quite expensive and is intravenous. So it's not reasonable to have like a 14-day course in a large part of the world, right?
That's correct. And so the what was recommended was the amphotericin deoxycholate,
Mm-hmm.
which, as you know, we've always known amphotericin as having that shake and bake syndrome, where it's awful side effects during the infusion process. And you're right; it's a 14-day infusion, so it requires someone to be in the hospital for that long. What is recommended now is the high dose ambisome. So that is a slightly different formulation of amphotericin that has less side effects, and it is nice that it is a 1 day treatment, so that patients don't have to stay in the hospital for 14 days of treatment.
Yeah. But that is does mean that like at least on that for that disease state, there is a disparity between how it's treated in the West and how it's treated in a lot of the other parts of the world. And I'm wondering if what about access to long-acting injectable antiretrovirals like cabotegravir,
We're
Cabenuva?
Yeah, no, we are trying to make that accessible, especially for pre-exposure prophylaxis. And I think we're piloting that or rolling it out in select countries. And we're trying to work with manufacturers to lower the price. I think that's important. Make sure that the price is lower, and so that countries can afford it. Because,
Because
this
that's
is
too new for it to be available through Indian generics, right? Still on patent.
so. I think that's the one great thing with the FDA tentative approval process is that we allow for even some of these brand drugs to, while it's still on patent, to be available for low middle income countries. Um, but there's some legality to it where they can only sell to low middle income countries or countries with high burdens of PLHIV, and need access to these quality drugs at a lower price. So it remains patented in countries like the U.S. or high income countries like uh, Western Europe. Um, and so that's how we have negotiated a lot of these to get around, the pricing issues with some of these new innovative drugs. I mean, that the technology is expensive, and we want to maintain that so that our pharma companies will continue to be innovative. Um,
Yeah, that's a great topic for another podcast. Um, yeah,
exactly.
the
Yeah. No. It's
innovation versus access. Um, well, I could talk to you about HIV all day, but I want to get back to your career. So, if you meet someone at a dinner party and they ask you, "What do you do?" What is your answer to that?
going to be very general here and call myself a public health specialist.
And you don't say public health pharmacist, you say public health specialist. Why is that?
Currently, in my public health career, I think my pharmacy skills and the training I received and knowledge, and especially in infectious diseases, definitely help in what I do on a day to day basis. But at this point, I don't really, go into the details of pharmacy. I'm not in regulatory or supply chain, which is like the two main areas that are needed when you think of what the pharmacist role is in public health. I did more of that with COVID in trying to roll out some of the COVID oral antivirals for test to treat programs in low middle income countries. And then and that was with USAID. And then recently I went back to HIV. I am a treatment advisor, so not necessarily working specifically with the drugs and which drugs we should roll out. I mean, like I said before, dolutegravir is doing very well. We may be working with some of the trying to roll out some of the long acting therapeutics. But for now, a lot of what I do is, ensuring continuity of treatment. I look at the country profile, I look at their data. Um, I support them in terms of how to get them to the UNAIDS 95, 95, 95 goals, which
Can you
includes.
say what that is for people who don't know?
Yeah, so the goal is to, let's say, if you have 100 people living with HIV, we want to make sure that 95 of them know their HIV status. Of those 95 who know their HIV status, 95% um, know their, is on ART. So that's, well, it turns out to be 90 people then. And of those 90 people, another 95% of them are taking their treatment every day. And if you were to do a blood test on them, they are what we call virally suppressed, meaning there's very little actual viral particles in a drop of blood. And I think that turns out to be something like 86 people then at that point.
Mm-hmm.
So and that's pretty much our main programming for HIV. And so as you can see, it's not necessarily about the drugs. We have a good drug. It's the issues of how do you find people who don't know their status? Do they want to be found? Even if they know their status, there are some people who don't want to be on treatment because the stigma of it, they feel like is worse than dying from HIV. And then even if they are on drugs, people cycle in and out of continuing on treatment for whatever reasons, like life gets in the way. We're talking about people in very difficult situations. They're poor, they have very little resources, they might be in conflict situations, there might be a lot of gender inequity, a lot of violence. And so taking their drugs every day is not on the top of their priority list. This is probably why or how a lot of these countries, where HIV has become such a problem. It's a disease of poverty. It's a disease of conflict and dire circumstances.
Mm-hmm. So it seems like there are these huge, you know, social, political, economic reasons why it's difficult to get 95% of people on HIV on antiretrovirals every day, 95% of those undetectable. So, what are some things that you've done to try to remedy that? Seems like, to me, a daunting problem. Can you give an example of something you've done to move the needle forward?
That's a great question. PEPFAR is a big program, and we have tried to bring in innovative solutions. And a lot of it is understanding the context of the country and the epidemic. I mean, it's different for every country. So, some of the strategies for finding people is we're trying to roll out index testing. We do that here in the US. So if index testing is if I find out I'm HIV positive, we have programs, someone to come interview me and ask me who my sexual partners are, and then and honestly I can say, well, John Smith, Jane Doe, and they'll ask, well, can I reach out to them? Do you have their phone number? And then they will do that, and they won't name me. They're like, okay, you have been identified as a contact. Can we then come and test you? Now, the resources you need for that person to do the interviewing, and the resources for them to go and get tests to test them so that we can identify who they are to put them on treatment is part of a big program. Um, and even if they identify someone, we have programs where we have case supporters or peer counselors where they will then perhaps help them navigate to these health facilities and get them on treatment. Um, and if, for example, if they were supposed to pick up their medicine, 2 months later and they missed their appointment, then we need a program where we bring in someone to call them, track them, ask them, hey, how are you doing? I saw you missed your appointment. What can I do? What's going on? We would love for you to come back. Are you in a situation where you can't even come? Can I bring your meds to you? So this is all part of a program. And as you can see, it requires human resources. And that's what a lot of our programs are. It's bringing in people, health providers to support these people living with HIV who may not be able to have the self-efficacy to do that. As I said, life gets in the way. A lot of these are poor people who move far away from families to work. They don't have the social support they need. They are hungry, and so our programs support them, and specifically for their HIV. But we know that if these people stay healthy, then they're in a much better position to
Mhm.
live a quality life and support their loved ones.
This is reminding me of Mountains Beyond Mountains, the Paul Farmer book, where in Haiti, he personally had to go on this 4-hour trek to deliver one patient's TB meds. I guess it was a DOTS thing, but yeah, you do what you have to do. But that seems like a wonderful goal, the 95, 95, 95. So your work is super cool, but you didn't start off doing this kind of programmatic work. You started off doing something a little more familiar to all of us, which was you were a professor at a pharmacy school, you had an HIV clinic teaching students. How did you end up in Lesotho?
Monica, I love that you mentioned Paul Farmer and Mountains Beyond Mountains. It was that book that made me want to go into global public health, specifically HIV. So early in my career, when I read that book and I was already on my trajectory towards pharmacy, and I was like, wow, I love what he does. And so that actually made me want to go into HIV as a pharmacist. Okay, that was the first step. And then I was like, maybe if I ever go into global health, that would be great. Um, but that was it. I went through my training. I loved infectious diseases. And then, of course, I specifically was interested in HIV. And sometimes life take you in on roads that you just don't expect either. I mean, my husband's infectious disease doctor. We both were interested in global health, but he was going through, gosh, decades of training, as you may know, with ID docs. But the same for us, ID pharmacists. It's a lot of post grad training. And, we were at some point interested in global health. And even before I went through my PGY2, which is a second year, for our audience who don't know what that is, it's our second year postgrad training in specializing in infectious diseases. We both realized if we do want to do global public health work, we should get some public health degree. And so that's when we went to the London School of Hygiene and did our master's in control of infectious diseases.
So you
But
did that between PGY1 and PGY2?
that's correct.
That's so cool.
But just we weren't sure whether we would actually use it. But if anything, it would enhance our skills and our epidemiology for infectious diseases.
Well, a friend of mine did that course too, and he came back to New York and he was showing me some of the material and he was studying for the exam. And the exam was you have to identify and name genus and species of 10 fleas and ticks. It's like, what? I
That's
mean,
correct.
it was crazy.
Right. I remember that we did a lot of tropical diseases that were neglected,
Hmm.
that most people don't hear of because that's what they are. They're neglected. Like some of the
Leishmaniasis
right.
and
Yeah. Yeah. Exactly.
river blindness.
Yeah. Lymphatic filariasis. Um, but Ebola, right? I mean, people have heard of Ebola, but that is a lot of the viral hemorrhagic fevers that you're talking
Mm.
about. Um, so yeah, it was great to go through that course. And then when I came back and did my PGY2, I knew right away that I wanted to do HIV. And you know, I got lucky. You know, I was going back to Philadelphia, and a academic position opened up for HIV pharmacy. And I wasn't, I didn't go in thinking I wanted to do academia. I wasn't sure I wanted to be a teacher. Um, but it was HIV, so I took it, and I absolutely loved it, Monica. It was I love teach. I learned that I love teaching. I love the topic HIV, and I got to see patients. I got to support them with their HIV regimens, counsel
And this
them.
was before integrase inhibitors. So, were you, a lot of patients were on ritonavir and you had to deal with drug interactions and stuff?
Yeah, so I was in this position for 5 years, and the integrase inhibitors came kind of later on towards the end of my 5 years. It was raltegravir that came out, and everyone
Hmm.
loved it. It was because it had very little side effects. Fortunately, it was twice a day, but it was a great go-to drug for a lot of my clients who could not tolerate a lot of the other regimens.
Hmm. I feel like HIV pharmacotherapy, it used to be like so important that you had a pharmacist on because of all the adverse drug reactions, the multiple pills per day, so adherence issues, the drug interactions. But now I feel like it's super simple, especially for your patients who are one pill a day. So you don't need to use that pharmacist part of your brain troubleshooting the drug interactions anymore. It's just like one pill a day. It's not like two pills in the morning and two pills at night, one in the afternoon. Avoid food with this one, eat with this one. It's so much simpler now.
That is
And
correct.
maybe less interesting. I don't know.
Oh, I agree. I have to say, at the end of it, I kind of got bored. It was like these drugs are so easy, and they have, and a lot of the integrates have much fewer drug interactions. They were one pill once a day. The pills were getting smaller. Um, and I didn't have clients who were coming in saying I needed, that they were having trouble with their regimen, because that was interesting. I would go through their resistance profile and, okay, let's see what we can put you on, what's available, and depending on what their complaints were, or what challenges they had, I would then, pull together a regimen that worked for them. But you're
It was
right.
much more of a Rubik's Cube back then.
That's a good way to put it, Monica. Um, and so exactly. It wasn't about the drug regimen. It wasn't about the drug interactions. It was a lot about the social issues that prevented patients from being retained in care and staying on treatment. And I think that's when I realized too that, like, this is where public health programming comes in. I wanted a larger impact. I think I feel like clients they could do this. We have the technology, we have the drugs for them, but it's a lot of the social economic challenges that I couldn't address as a pharmacist. So, for example,
Hmm.
a lot of my clients, at that point, some of the drugs required food, and I remember asking one patient, was like, "Well, why aren't you taking it?" And it took, I think, 10 visits for her to finally trust me enough to say, I don't have food. And I think she was
Mm.
just embarrassed. She was embarrassed. She finally trusted me to kind of be vulnerable, to tell me that she did not have food. And when she does not have food, she does not like taking her meds, because some food in her stomach really helps with some of the stomach side effects. And then I'm like, okay, I can help you. by walking you over to the social worker, you know? And that was
That was
like
your
my,
intervention.
yes, that was my big accomplishment for the day. Like, but yeah, these are just some of these challenges that people living with HIV have.
So you go from this practice that you were probably like you were loving, but it's in another sense you're craving something bigger and different, and which you ended up having this great opportunity to go somewhere very different, Lesotho. What was that like moving from Philly to Lesotho?
It was scary, I'll admit. I was leaving a very good job. I was starting to publish a bit, and because that's what happens in academia, and
Publish
and
or perish.
right, exactly, and kind of making a name in the HIV world, and you know, my husband looks at me one night and was like, "Hey, remember we wanted to travel the world and do global public health work?" And I look at him, yeah, that was 10 years ago, or maybe it
Before
wasn't
you
that
had
long.
two kids.
Right. At that time, I had a 6-month old and a 3-year old. And Monica, I don't know if you have kids, but it was like at that moment, I'm like, I'm thinking about breastfeeding here and like maintaining this very good job that I have where I can feel fulfilled in my career and still be a mom. And he's looking at me like, let's move overseas. And in the beginning, I'm like, no, no, we're not. I'm not doing this right now. This is a bad time. And I think, after some conversations, I did think about it and I was like, well, this was our passion. This was my passion. This is what I wanted to do. And if I don't go now, I think
Hmm.
life will just get ahead of me
Hmm.
and things will just get, I'm just gonna want to be more and more comfortable. It's not going to be easier. Being a parenting never gets easier. I don't know what people ever tell you. And so um, it's either go now and this is our time. And I feel like if I didn't go now, I just wouldn't ever go. And I thought about, I weighed the risks, leaving this great job, but I was thinking, if it doesn't work out, it doesn't work out. We'll come back. We can come back. I'll find something else. But still, it's scary, because you never know what if this was your one chance at an amazing career, and you're giving all of that up. Um, and I guess you just do it, and
So
just
you did it.
yes.
Amazing. And then when you got there, tell us a little bit about how because you know, as your husband is a physician, so physicians are acknowledged universally as, you know, they diagnose, they prescribe. It's pretty clear what they do. But pharmacists outside of a few countries, including the United States, is very unclear as to what their skill set is, what their capabilities are, the licensing thing. Like, for example, when I went to India, when I finished pharmacy school, my cousin, who was 18 years old, owned a pharmacy, and people would just come up to him and say, I'm sick. So he would give them a box of Cipro. It's like, oh God, please don't do that. But there's
Right.
no licensing. There was no regulatory requirement for an education to be able to do that. So I go there. I don't know if I could work as a pharmacist. So what did you do as a pharmacist in Lesotho?
Right. I mean, as you know, pharmacy, the way it's practiced can really differ depending what country you're in and what pharmacists are allowed to do. And, the US is rather advanced in terms of clinical pharmacy and our ability to kind of work very closely with physicians and supporting them with drug regimens. Um, there wasn't really much of that in Lesotho. I did try. There was a school of pharmacy where we were at in Maseru, which is the capital of Lesotho. And, I try to see, well, I knocked on their door and say, here I am. I'm a pharmacist and I was actually teaching. Can I help? Can you use my skills or services? And they're like, yes, we need someone to teach pharmaceutics. I'm like, um, I took 2 semesters of pharmaceutics. It's going to require me to like dust off some notes. And it wasn't what I wanted to do. I don't like pharmaceutics. I
Same.
mean, it's kind of fun making your lotions and triturating. And that's all I remember about pharmaceutics, triturating, because I actually thought that was pretty amazing. The idea of like, using a little bit of powder and putting it in whatever vehicle and then keep on adding this.
Aliquots.
Right, right. But that's all I remember. And I'm like, no, I don't think I can do this. So then I decided, all right, let's go the full public health route. In Lesotho, 1 in 4 people are infected with HIV.
Mm.
You can, sometimes, if you think about it, it's in a room, you count 1, 2, 3, 4, like this is how many people are infected with HIV.
It's the highest prevalence in the world, right?
Mm-hmm.
Or was?
Yep. It's always between 1 or 2 with South Africa. And so there are a lot of PEPFAR was there supporting a lot of their programs. It's a population of 2 million people. And a lot of organizations received the funding to kind of implement these programs. And so I literally knocked on every single NGO door, and kind of gave them my CV and said, here I am. Can I help? I was even willing to volunteer because I realized that, I needed some experience. I have this amazing degree, the PharmD degree. I have like 2 years of post-grad training. I have an MPH, but absolutely no experience. So I just wanted to get some experience, and maybe more opportunities would open up for me. So I was willing even to volunteer. And there weren't many NGOs in Lesotho. I mean, it's a small country, but all it took was one. So ICAB, which is associated with Columbia University,
Mm-hmm.
they were implementing PEPFAR programs. They came back and said, well, we do have this one project that we need you to kind of, fix or, bolster. And it was a mobile health application program. So they were using an application on a phone to support client management. A lot of it was for TB programs. If you had like someone, a Lesotho citizen, we call them Basotho, who were working in the South Africa mines. A lot of them work in South Africa. If they need to come back to Lesotho because they were actually infected with TB, so they're repatriated. This program, using a mobile application, ensured that they were being tracked, they were being connected to another health facility, whatever other health problems, and usually HIV, they had a high HIV TB co-infection rate.
Mm-hmm.
Would then also be making sure that they're on their HIV medicines and all of that. So it was this mobile health application that at some point I learned to code and build this
That's awesome.
application, which was, if you ask my husband, I know nothing about technology. I'm the worst. But I figured it out. And, I think that's one thing great about pharmacists. We learn, we see a problem, we solve it. And, it's not necessarily what you actually learn the content. I mean, there's always new drugs coming out. You always have to learn new drugs. And the drugs that you learned in pharmacy school are probably no longer being used. But it's the skills, right? And I think that's what I kind of applied our problem solving skills and just attention to detail. I mean, pharmacists have to pay attention to details.
Very meticulous.
Exactly.
But what I love about this story is that here you are, you have this in-depth knowledge of antiretrovirals and HIV management, and you go to the country with the highest prevalence in the world of HIV, and it's still like challenging for you to find a job. Ultimately, after trying and trying, something falls in your lap, and it's for, kind of what you do, HIV and TB, but the main focus is not like pharmacotherapy. The main focus is like technology, using technology, building an app. But you're like, I'm going to do this. And you did what you need to do to help move that along, which speaks to your tenacity. And it also, that's like a reoccurring theme among all my guests is like, have to keep trying until you get something. And then so you do this, you make this technology, and that means you're getting some experience there doing work, doing public health work. So after that was done, it must have been easy for you to get your next gig, right?
It was
Relatively.
definitely easier because, I mean, first of all, they would have ICAP would have kept me on, but they lost their funding. They did not get the follow-on award. Um, but in the development world, if there's funding, it's just who gets the award. And so another organization did. It was EGPATH, the Elizabeth Glaser Pediatric AIDS Foundation. And then they often sometimes do sub awards. And so I ended up working with Baylor because Baylor was a sub award for them. And it helped because I was, at that point, they're like, okay, so she understands Lesotho. She's actually done some HTB programming. They actually, within the country, they liked this mobile health application that they wanted to continue. Um, I didn't continue it with this new position with Baylor, so I got a position through them doing pediatric care and treatment and supporting their programs. But that definitely helped where, after a while I knew the country and they wanted someone with my skill set and kind of understanding the context.
That's great. And how long did you do pediatric HIV therapy with
So
Baylor?
2 years there, and then the deputy PEPFAR coordinator position opened up at the U.S. Embassy. So that's full on work with the U.S. government, and I was like, I'll give it a shot. I wasn't expecting to get it, to be honest, Monica. I thought, they were, it was a pretty big deal, and people who have worked years in public health that would get positions like that. And while I had a doctor of pharmacy degree, I definitely had the technical knowledge, but again, I did not have like the public health programming experience that was probably needed for this position. I ended up getting the position, which I'm so grateful for.
And that was
Um,
with USAID or with the State Department?
that was with the State Department.
Okay.
Um, and I think part of it was again because I at that time had been working in Lesotho for about 2.5 years. They really wanted or liked the fact that someone understood Lesotho in the terms of its context. A lot of times, you know people coming into new countries to work, it takes about a year to fully understand the culture, and how to work with the locals. And so I think that gave me the advantage.
And what was it like living there with two kids? Did you have access to childcare and did you have like a nice place you were staying in, or was it very rural and minimalistic like people envision?
Yeah, we did live in the capital, and so there were, brick and mortar houses, not mud huts or anything like that. There was a big difference between when, so we first came through with Baylor through my husband's job, and housing was it was humble. I'll just say that, and I did see the difference when I moved with the U.S. government. There was a lot more support, um, where I almost was like, how did we do this? How do we move, halfway across the world all on our own without this kind of support? But we figured it out. We kind of sold everything and packed all our life possessions into 16 pieces of checked luggage. That was it. Um, it wasn't about the things that we needed. One thing nice about being in Lesotho is we had a lot of help. It was I had a full time nanny who was able to like be with my kids. So I think that was really helpful, especially for
Yeah.
someone with young kids. So it wasn't all struggle, and I won't, play the oh, I sacrificed so much to live in a country like Lesotho. There were definitely good things about it too, especially all the extra help you get with young kids.
And what a great experience for your kids too.
They really loved it there.
Yeah. And after how many years did you return stateside?
So we were there for close to 7 years, and then
Hmm.
came back to the U.S. We kind of knew that at some point we would have to come back when our kids got a bit older and going beyond primary schooling. Lesotho was, like I said, was just very small. The American International School was very small, and we needed something more for our kids. So it was either go to a bigger African city, or it didn't even have to be in Africa, but just a big enough city that there was, a bigger school, or come back to the States. And, we ended up coming back to the States more so, and because, where my husband was applying. And I keep on saying this, that it's my husband leading first. That was just the decision we made as our family. I think every family's different. With
Hmm.
two people with careers, Monica, you understand. You have an amazing career. Your husband does too. And when you have a family, you're like, or even just the two of you, you're gonna have to compromise and figure
Yeah.
out who's going to be the one following, or vice
Right.
versa. And that was just the decision we made as a family.
Yeah. Well, I live in Washington, D.C. We moved here in August from New York City because my husband had a job opportunity to work in a think tank here. And I was nudging him to do it because I wanted to pivot out of hospital pharmacy and into government or non governmental organization, do humanitarian work. And we do have a son who's 5, and there are great public schools here too. Um, where we would have a very costly private school in New York City. So I think I get what you're saying. You have to think about each person individually and as a family to see what's best for everyone in aggregate. And it
Yeah,
sounds like it's so nice that you and your husband are both like global health, infectious disease. So there's like a synergism between your work. Like, what if you were I don't know, firefighter? So that may not have worked out. So I think your career paths were in parallel. So that's what helped all of the
agreed.
flow
Yeah.
for you.
I don't know how others do it, right, when the careers don't align very well, but I feel like every family figures it out. And while we you know, figured out that he would look for the job, and then, it's just too hard for both of us to try to like get some kind of match going, right? It's not like,
Hmm.
medical residency matching here, where there's that kind of system. So I was, allowing him to kind of look for his job. And so he got a position in Boston here. And then I was like, all right, fine. We'll move to Boston, and then I'll figure something out. But Monica, it's still scary.
Hmm.
I loved my job in Lesotho. Um, I loved what I was doing. I
It sounds
loved
like a perfect job for you.
it was amazing. Um, so I wasn't sure what was going to happen. Would I be able to get something similar? And there are a bunch of public health NGOs here in Boston. There's
You're so qualified at this point. You have done it all. You got a PharmD, you did 2 years of residency, you did London School of Tropical Medicine and Hygiene, you worked in, the country with the highest prevalence of HIV in the world for 6 years doing like hands-on work. I feel like when you came to Boston, you should have been like, who wants me? Let me negotiate. I can get all of you. I feel like you were perfect candidate for any job. Was it like that? Was it easy to get your next job and was it perfect for you or was it still challenging?
It was still very challenging, I must admit, because you look at the job market and you look at what positions were open. Okay, so there were some, there are public health positions opening, but is it the one that you want, right? It wasn't exactly what I wanted to do. I wanted to continue with HIV, and a lot of the HIV programming, was still with the U.S. government, and a lot of the major NGOs are in Washington D.C. So I'm like, oh, well, in Boston, it's gonna be a problem. Um, and it was, I was trying to apply for many jobs through USAID, and I was not getting any callbacks.
That's so shocking to me.
It's hard. I mean, it's a big. I mean, first of all, it's slow, so
Hmm.
you can be waiting for a while. Um, but I got one interview, and I was not qualified for it. It was a very senior position. But whatever. I'm like, all right, let me just interview. And it was someone on that interview panel who then called me back and say, hey, you didn't get this job, but we actually need someone for COVID. It's temporary. It's nothing permanent. Would you be interested? And I think because it's not permanent, they had a lot of trouble getting people,
Mm.
for positions like this. And I'm like, yeah, I'll do anything. Part of it is, again, I had this mentality is like, try it out. If it doesn't work out, it's fine. It's temporary, but you never know. You open one door, other doors may open, right?
Yeah,
That's just kind of, how I,
that's a good pearl.
so I took on this COVID position, and in the meantime, I was continuing to apply for USA jobs. And by that time, people started to like know me, and they knew my work. I was doing some mini presentations here and there about the status of COVID. And so
And you
after
wrote a really great paper on how COVID affected management of HIV throughout the world.
exactly, we were trying to leverage, the PEPFAR platform for COVID implementation, which was great to see that we were able to use, the systems that PEPFAR has built up for that. Um, but yeah, and so one thing led to another. A door opened where I was, applying for another job, and since people kind of knew me and they knew my work, I was able to get a permanent position at USAID, going back to HIV, which is what I really wanted to do. But in many ways, COVID doesn't really leave you. And now I'm doing some work with global health security, which I think is important, especially when we realize that, we live in an era of globalization and diseases can spread very, very quickly.
And
And
PEPFAR wasn't reauthorized, right? But
not
it's
yet,
going to be. It's got to be.
not yet. We're all keeping our fingers crossed. The Global Health Security and Diplomacy Bureau is really working hard to making sure that it gets reauthorized.
So what's next for you? What does the future hold?
It's a great question. I don't know. I think I'm very happy what I'm doing now. I imagine that as health changes, I think as we reach epidemic control for a lot, HIV epidemic control for a lot of countries, something else may come up, and I might jump over to some other health priority. But I'm excited. It's I think these several years have made me realize that don't be afraid to just take these risks, and if a door opens up, go through and see what else opens up for you.
That's great advice. What else? What other advice do you have for pharmacists who want to go into global health?
I'd say if that is really what you want to do, don't be afraid to start small. Sometimes you have to. Um, I think pharmacist has gone through so much training, and you guys, we put in a lot of hard work, and it's hard not to be like paid for it and recognized for it, right? And so I think if you want to kind of start a new career, you're going to have to be okay with maybe taking a lower paid position for a time being, and kind of working your way up again. But I think when people realize that you have the skill set and you have different experiences that you can bring to the public health space, you will then be recognized for it. But it may not happen, for in the first 1 or 2 years. I think that's important. And if you really want to, again, if you have trouble, looking, finding some paid positions, looking to fellowships or other training programs. I'm with USAID, but I'll be honest, in the beginning, when I wanted to get into the public health space, I tried to apply for CDC's, the EIS program, the Epidemic
Yes.
Intelligence Service. So I'll tell you this, Monica, I applied twice and was refused twice. Like the first time I applied, this was before I left for Lesotho, I didn't even get an interview. The second time I applied, this was actually, I applied after I came back from Lesotho, and I'm thinking, all right, like maybe this will help me get into CDC. Because I was applying to all these jobs. I wasn't getting anything. So I was like, all right, I'm willing to go back and just do a fellowship, and applied again to EIS, got the interview, but did not get selected. So, it's fine, but you try it. And I have a good job at USA now, and it's worked out fine.
Well, thank you for sharing that, because I think, you see someone doing the kind of work that you do and you just feel like, wow, she's so lucky. She's so smart. Nothing can stand in her way. But then you tell stories like that and you realize, wait, I'm not alone, because now I'm talking about me personally, not theoretically. I've gotten rejection letters for jobs that I thought I would be so perfect. And I was stunned by that, but it hasn't, it happens to all of us, and it's just part of the process. And we just have to stay on target and keep going.
Oh, exactly, Monica. We people don't ever talk about their rejections, right? And our failures, right? But Monica, I would encourage you to just keep at it. Something will open up,
Yeah.
I think the persistence, will pay off, and you'll figure it out. And and if not, I'm loving this podcast. So, maybe it turns into this.
Yeah. Yeah. Yes. No, I'm definitely not suffering, and I'm having a blast meeting people like you. Gosh, thank you so much, Carol, for sharing your story with us, your super cool career path, paving the way, your tenacity, and sharing us all the cool work that you're doing with HIV.
No, thank you so much for having me, Monica, and considering me.
Of course. Thank you for listening to Career Reconstituted, how these pharmacists turn their job into a dream job. My name is Monica Mehta. To our listeners, thank you for spending your hour with us in a world where time is a rare commodity. If you have any comments, questions, or recommendations for interviewees, please get in touch via Spotify in the episode notes page or on Instagram. Look for a handle career_reconstituted. And if you like the show, please subscribe or leave a rating. Until next time, bye friends.